Hello and welcome to this video on abdominal aorta ultrasound. My name's Aaron. I'm an emergency medicine registrar currently working in the UK. And if you're wondering what that snowman's doing there, well, you might already know, but if not, then it'll become a bit more apparent later on. What are we going to cover? Well, we'll go very briefly through the importance of ultrasound assessment of the abdominal aorta, a bit about the anatomy, and then the views that are required to assess the aorta, a bit about troubleshooting, and then a brief summary of things. So why is it important? Well, we know ruptured abdominal aortic aneurysms are often catastrophic and fatal. So rapid diagnosis of a ruptured AAA can lead to improved survival for these patients. However, early diagnosis of an unruptured AAA as well can also lead to earlier referral to a specialist who's able to provide earlier intervention and potentially improve survival for these patients if they were to rupture. So from a clinician point of view, it's important because assessment of the aorta using ultrasound is one of the core emergency medicine point of care ultrasound skills that are required for ED, EM clinicians. And it's got a high sensitivity and specificity for the presence or absence of aneurysms. So it's a very good skill to learn if you're an A&E clinician. So what are the indications for performing this scan? Well, on the right here, we've got a poster from the Royal College of Emergency Medicine that came out quite a few years ago now. It's from 2016, but it highlighted that abdominal pain, especially in older patients, is often the cause of diagnostic uncertainty, and that these patients have a significant increased risk of mortality compared to younger patients. And they specifically mention AAA as one of those causes of this. NICE guidelines also recommend that patients presenting with suspected renal colic, especially if they're aged over 50 and male, because they have a much higher chance of having an aneurysm, you should consider the presence of an aortic aneurysm as well. And this scan can also be done in those patients presenting with undifferentiated shock using protocols such as the Rush protocol in order to try and identify the cause of shock and hypotension. Now at the bottom of the screen, there's something from the Royal College of Emergency Medicine, and it lists a couple of patient groups that need discussion with a senior doctor. In the UK, this is considered a higher registrar or consultant before these patients are discharged. And at the bottom we see abdominal pain in patients aged 70 years and over is one of those. And this goes back to this safety alert that's on the right of the screen that's suggesting that or showing that abdominal pain in an elderly demographic is associated with an increased mortality compared to younger patients. So when performing ultrasound assessment of the abdominal aorta, what is the question that we're asking? Well, as with all point of care ultrasound, we should really try and pose a binary question that has a yes or no answer. In this case, the questions are, is the abdominal aorta larger than 3 centimeters? And are the common iliac arteries greater than 1.5 centimeters? It's important to remember from this that when we're doing this scan, we're looking for the presence or absence of an abdominal aneurysm, not whether it's ruptured if there is an aneurysm present. And this is important to remember. So there are some papers showing subtle signs that occur when rupture has occurred in a patient with an aneurysm. However, for the most part, just stick to the binary question here. You're just looking for the presence or absence of an aneurysm. Now, the majority of aneurysms, when they do rupture, they rupture retroperitoneal. So it's unlikely that you're going to see free fluid. However, you can also look using the fast views, just like you would in trauma, for free fluid in the intraperitoneal space. However, you just have to remember that, as we've mentioned, they mostly rupture retroperitoneal, and this space isn't visualized very well with ultrasound, so likely you won't see any fluid even if it is there. And also you have to consider that just because you have an aneurysm and you have fluid in the abdominal cavity doesn't necessarily mean it's come from the aneurysm. Obviously, in the right context, with the right clinical suspicion, you're going to assume that, or you may assume that, but it doesn't mean it's definitely the case. And it's important to remember just to take the measurements in the AP, the anterior to posterior diameter of the vessel. So this scan is looking at the abdominal aorta only. We're not able to really visualize the thoracic aorta very well using ultrasound. So a brief bit about the anatomy of the aorta. We can see from the picture here that I've tried to simplify it a little bit and input just the important branches on the screen. So it starts roughly at the level of T12 and ends at around L4 and is roughly 12 to 13 centimeters in length. And as we mentioned from our binary question, we want to see that it's less than 3 centimeters, as the aorta should measure less than this. And there are lots of other branches, but as we mentioned, keep it simple here. So the branches we're really interested in is the celiac trunk, or the celiac axis, the superior mesenteric artery, and the aortic bifurcation. I have on the picture put the renal arteries as well, and we'll come back to that. From a PoCUS point of view, they're not particularly important. So how do we do the scan? Well, at the bottom of the screen we have a picture here showing the aorta and the IVC and the vertebral body and their relationships to each other. Using the vertebral body as a guide is often important, or is often useful in order to identify the aorta and the IVC. The vertebral body will cast an acoustic shadow behind it because of an absence of waves that are able to pass through the cortex of the vertebral body. So this can be used as a good landmark to identify what you're looking at. And then anterior to this, you'll see, or you should see, two varying size structures, one slightly over to the left and one slightly over to the right. Now it makes sense that the one slightly over to the left is almost always going to be the aorta, and this is usually more rounded and is pulsatile. However, there's a table here that shows some of the differences between aorta and IVC. It's really important that you consider all of these differences when trying to differentiate between the aorta and the IVC, because for obvious reasons, if you measure the IVC, then you're going to run into problems. So the IVC is slightly over to the right, aorta slightly over to the left. The aorta is circular and pulsatile, and is often visualized to have a thicker wall. However, especially in younger patients, this might not be particularly obvious, and you can't compress it if you were to push hard enough. The IVC, on the other hand, the shape is quite variable. It can be round, it can be oval. People often describe it as pear-shaped or tear-shaped, but it may not be visible at all in certain situations if the patient is extremely dehydrated or hypovolemic. An important point to remember is that it may appear pulsatile, and that's not because it actually is pulsatile like an artery, but it's just because of its proximity to the aorta. It's also got a thinner wall, and in theory, like other veins, if you to compress them, they should disappear. However, in the abdomen, it's variable. You might have to press extremely hard in order to be able to do that. So when scanning for the abdominal aorta, you really need to take 5 views in order to exclude the presence of an aneurysm. If you don't see it along this entire length, then you haven't really excluded the aneurysm. And it's quite common that it's not visualized at part of this because of bowel gas. Usually it's the more proximal part where other things like the transverse colon, stomach and small intestine might produce extra bowel gas and get in the way of your image. So these 5 views, and we'll go through each of these in turn, are the proximal aorta, the mid-aorta and distal aorta, and then we have the bifurcation of the aorta, and then one view in the longitudinal measurement is also required as well. So for this scan, we're going to use the curvilinear probe. It's often referred to as the abdominal probe. It's a low-frequency probe, which means it penetrates better into the body, so is good for looking at abdominal structures such as organs and the aorta. But it should be noted it produces a poorer resolution than would do the vascular probe that's used for putting in vascular access and performing nerve blocks. However, on balance, you need to mix the penetration with the resolution, and therefore this probe is the best one to use for that. So here we can see the probe placed on the abdomen with the probe marker towards the patient's right side, and the probe is just moved superiorly and inferiorly to cover the distance between the proximal aorta down to the bifurcation of the aorta. It doesn't matter too much particularly where you start the scan, as long as you make sure to take all the measurements as we've mentioned. So starting off at the proximal aorta, so the celiac trunk comes off anteriorly, and in the picture at the bottom of the screen you can see this. So the aorta is visualized near the bottom of the screen. Coming off anteriorly, you can see the celiac artery, and then this divides into the common hepatic artery on the right and the splenic artery on the left. So the celiac trunk, the hepatic artery and the splenic artery combined is collectively referred to as the Siegel sign, and this is quite obvious from the picture that we can see there. It's important to remember that you don't always visualize this. Sometimes that's because of bowel gas obscuring the view, and there are some slightly abnormal variant anatomy that some people have, so that they don't always have the celiac artery, common hepatic artery and splenic artery in this configuration. So how do you know that you're the most proximal, so that there's no chance of missing a very proximal aortic aneurysm? Well, if you see this sign, then you know you're very proximal, because it's the most proximal part of the abdominal aorta. If you're not able to see it though, it is a little bit more tricky. However, if you've got the probe lodged right up under the xiphisternum, high up in the abdomen, and you're able to see the aorta underneath, but you can't see the Siegel sign, you can't see the celiac axis come off, then you still know that you're the most proximal that you can possibly be, and that you're not going to miss any aneurysm in this segment here. Just below the celiac axis, the superior mesenteric artery comes off. This comes off anteriorly and then rapidly turns 90 degrees and runs parallel to the aorta. So you can see in the ultrasound image here that the SMA, the superior mesenteric artery, is seen as a small circular object that sits just above the aorta. Now, you can see that the vertebral body, aorta, the SMA and the IVC all have a relationship to each other in that they form what is referred to as the snowman sign. And you can see in this diagram over to the right that in theory, the vertebral body is supposed to represent the body of the snowman, with the IVC with its kind of teardrop shape representing the scarf, the head of the snowman being the aorta, and the hat being the SMA. Now, sometimes you can persuade yourself it does look a bit like this, other times it looks nothing like this because of the anatomy being slightly different. But in theory, the snowman sign is what people like to think of the superior mesenteric artery and the other structures' relationship as. If you can identify the superior mesenteric artery, well, that's good, because again, you know you're quite proximal. You know that you're just below the celiac axis. However, again, similar to the celiac axis, it's not always visualized. This doesn't matter, just like the celiac axis in a way, because we're not looking at the SMA in order to measure it or define it in any other way. We're simply using it as a landmark to try and identify that we're at the most proximal part of the aorta. As we come down a little bit then, so we get to the level of the mid-aorta, and where should you take the measurement of the mid-aorta? Well, somewhere between the proximal and distal is sufficient, really. We can see on the ultrasound image on the left that we've measured this aorta. We don't have the measurement on the screen there, but we've measured from the anterior to posterior diameter, and we can see how well the vertebral body shadow acts as a landmark to try and identify both the aorta, as we can see that's measured slightly over to the patient's left, and the IVC that we can see as well slightly over to the patient's right. Now, the renal arteries may be seen somewhere around here. We've alluded to it earlier. Is this important for PoCUS? Well, not particularly. It makes a big difference for the vascular surgeons themselves whether an aneurysm is juxtarenal, suprarenal, infrarenal. From a PoCUS point of view, remember going back to our binary question, the binary question was simply, is the aorta larger than 3 centimeters? So if you see the renal arteries, great, but similar to the SMA and the celiac axis, we're not really seeing them for any particular reason from a PoCUS point of view. I guess the only caveat to that potentially is that we know most aneurysms are infrarenal, so the majority are below the renal arteries. Therefore, if you can clearly visualize everything below the renal arteries and there's no aneurysm present, the aorta is a normal size, then it's probably less likely that you're going to miss a suprarenal aneurysm. However, I wouldn't rely on this as during your scanning. If you don't visualize the aorta through the entire length, then ultimately your report is going to have to say that if bowel gas is in the way, for example, that the view is obscured by bowel gas and that you haven't seen the aorta along its entire length. As we come down a little bit more then, so somewhere on the picture we can see just above the umbilicus, or just around the level near the umbilicus, we have the distal aorta. And in this picture I have measured both AP and lateral from side to side. However, should remember that for a curved object like an aorta, the lateral walls are often quite indistinct because of the way the ultrasound beam hits the curved structure of the lateral wall. So really the measurements should be taken anterior to posterior, as we've done in the previous image. Finally, if we come down a little bit more, so just up or just below the level of the umbilicus, we can see the aortic bifurcation. Now, here we need to measure both of the iliac arteries and take the measurement just after they've bifurcated. Our binary question, or one of the binary questions as we mentioned earlier, is are the iliac arteries less than 1.5 centimeters? And that's the question we want to answer. Often in this view, as you're trying to get the iliac arteries, you find a lot of air is getting between the probe and what you're trying to look at, and it creates a very strong void of ultrasound waves, and this manifests as a shadow that obscures the view to what you want to see underneath. The best way to avoid this, some people try and force a lot of jelly into the belly button. However, you're always going to have small little pockets of air that form in there, and that will always obscure the view a little bit. So if you just move the probe slightly lateral to the umbilicus, either way, either over to the left or the right, it's probably better over to the left slightly because the aorta is slightly on the left side, and then just tilt the probe a tiny bit back towards the vessel. And this way you should be able to see the bifurcation and the distal aorta, but you've just managed to avoid the large umbilicus shadow that was obscuring your view. So we've taken the 4 transverse views that we need. How do we get the longitudinal view? Well, we just rotate the probe 90 degrees clockwise from where we had it in the transverse view so that the marker faces towards the patient's head. So once we've done that, we need to take one measurement in the longitudinal view. Usually, unless the vessel is extremely tortuous, you can usually get the whole of the aorta length in one view, but sometimes you might need 2 or maybe even 3 views of this. You need to ensure that the measurement is taken perpendicular to the vessel to avoid kind of a salami slicing effect where the vessel appears bigger than it actually is. So in the middle picture at the bottom of the screen, we can see we've taken measurement of the mid-aorta perpendicular to the vessel, so we get the correct size. Over to the left on the image, we can see the celiac trunk and the SMA coming off proximally. And you can see in this picture how the celiac trunk seems to come off sometimes at 90 degrees, sometimes it's a bit more angled as it is in this picture. The SMA just below it comes off anteriorly and then rapidly turns 90 degrees. So as we mentioned earlier, it runs parallel to the aorta, and that's why you see it as a small circular object just on top of the aorta. So here we see a sweep down the aorta, starting proximally. Firstly, we see the seagull sign, so we can see the celiac trunk coming off anteriorly and dividing into the hepatic and splenic arteries. Just below we see the snowman sign, so we can see the relationship between the vertebral body, the SMA, the aorta and the IVC. And as we sweep down through the mid and distal aorta, we end up at the bifurcation where we can see both common iliac arteries. So, just a little regarding measurements. So, it's important to remember that measurements should be taken from the outer wall to outer wall, and thrombus counts towards the measurement. In the picture we have here, so the calipers show that this aorta, including thrombus, measures 4.19 centimeters. That's with the dotted line of the calipers, but the straight line with arrowheads shows the inner lumen of the vessel. So I haven't measured that, but you can see if we didn't include the thrombus in the measurement, we would significantly underestimate the size of the vessel. So it's really important to remember that any thrombus you see needs to be included in the measurement. Now, sonographers, when they scan, they measure the inner wall to inner wall, but it's important to remember also with that That still includes the thrombus. They're just trying to identify the exact wall of the vessel a bit more clearly. In the image again, you can see that the anterior wall isn't particularly distinct, but posteriorly it's outlined a bit clearer. So you'd probably be able to identify the outer wall or inner wall of the posterior wall, but the anterior wall is very difficult to actually determine where the inner and outer part is. So for that reason, you're probably better off overestimating the wall a little tiny bit rather than underestimating it. And definitely remember that thrombus needs to be included in these measurements. Troubleshooting. So quite commonly, excess bowel gas gets in the way. So what can you do about that? Well, often it's a case you just need to press a bit firmer. Now, obviously, the demographic of patient in whom you're going to be doing this scan may not tolerate you pressing firmer. A lot of these patients, even if they don't turn out to have an aneurysm, firstly, they've come in with abdominal pain, so are likely to be tender in their abdomen, but also may have other pathology that produces gas or otherwise obscures your view. So it may be that you can't actually press any firmer, but if you can, pressing firmer may help just displace some of the air that sits between the probe and what you're trying to look at. Sometimes, rather than just pressing firmer, you can use little small movements of the probe, just pressing a tiny bit and tiny bit more, and just gently trying to force any little pockets of air out of the way so your view is a little bit better. If you get a poor view of the proximal aorta, as is quite common, as it descends a bit more posteriorly here, you can use the left upper quadrant EFAST view in order to identify the aorta. So in the ultrasound image we have here, we can see that the depth has been increased a little bit more than you would use for FAST, and we can see the spleen and the kidney towards the top of the screen, but with the depth increased, we can see that the aorta runs along the bottom of the screen, and the IVC runs even lower. So this left upper quadrant FAST view can be really good in order to identify the aorta proximally if there's too much bowel gas in the way. And on these views, remember, you're using the spleen and the kidney as acoustic windows in order to propel the ultrasound waves through to deeper structures, whereas anteriorly you have too much bowel gas in the way. You can also use the right upper quadrant view if you prefer. However, of course, just remember that the first vessel you come across will be the IVC and not the aorta, and obviously that makes a difference. You need to make sure you're measuring the correct place. If the abdomen is too tense, then you may not get good enough views. You might not be able to press adequately, and you can try and ask the patient to bend the legs, and that might loosen the abdomen a little bit. If you're unable to get any views, then ultimately you can't rule out the presence of an aneurysm, and therefore you need to consider what to do next, and that most likely will be getting some alternative form of imaging like a CT angiogram. However, it obviously depends on the clinical history as well as to what type of CT scan you might get. If there's a very strong suspicion of this, it might be, and you don't have vascular surgeons at your site, it might be that rather than doing the CT on site, you arrange to transfer them to a site with vascular surgery. So obviously that will just depend on what hospital you're working in. But ultimately, the key point of that is if you can't see the aorta along its entire length, then you're not really ruling out the presence of an aneurysm. Just be a bit wary of patients who have had previous surgery before. So in this example, you can see the calipers have measured the aneurysm sac, and towards the top of the screen, within the aneurysm sac, there's two structures which are stents. So the measurement we've taken is of the aneurysm sac itself. Now you may be able to compare this to the previous scans they've had done to see what size the aneurysm sac is. However, I'd be a bit wary of doing this. Remember, going back to your binary question, the binary question was, is the abdominal aorta greater than 3 centimetres? And in this case, it is larger than 3 centimetres. So you've answered your question already. Remember that even if they've got stents in, you can still develop endoleaks, and this aneurysm sac can still enlarge, and it can ultimately rupture, just like an aneurysm in somebody who hasn't had any stents in. So be a bit wary when you see these, and I'd probably lean towards definitely a discussion with the radiologist about getting some alternative form of imaging if the clinical history is suspicious of an aortic aneurysm. Now, in terms of documentation, what should you document? Well, I recommend keeping it simple, something along the lines of what I've written here. So aorta visualized throughout entire length in both transverse and longitudinal views, aorta less than 3 centimeters, common iliac arteries less than 1.5 centimeters, And you can mention who you're supervised with if you're not signed off to perform it solo, yourself. And then document it with your name, maybe your job role and GMC number. You can put the specific measurements if you want in. So if you've measured the maximal diameter of the aorta to be 2.4 centimeters, you can put that. However, I think it's acceptable to just put, again, going back to your binary question, it was, is it larger than 3 or larger than 1.5? Yes or no. So we're saying, look, we've answered a binary question here. There's no aortic aneurysm. So we don't necessarily need to document anything further than that. If there have been parts of the aorta that you've not been able to visualize, then of course write it here. You'll commonly see written aorta not visualized well due to bowel gas, or not seen proximally due to bowel gas. So you can put that here in the documentation section, and it may be in your clinical notes later that you justify the reason for doing a further scan, or maybe for not doing a further scan, but just keep the report factual and leave any opinion as to what you're going to base, what kind of clinical management you're going to do based on your scan, leave that to another place. In summary, so remember the binary questions that you've asked, and this is important for all point of care ultrasound, all PoCUS scans. So in this case, is the abdominal aorta greater than 3 centimeters, or are the common iliac arteries greater than 1.5 centimeters? And it should be yes or no. You're assessing for the presence or absence of an aneurysm, not whether it has ruptured. And that's a very important point just to remember. You need to obtain 5 views, as we've discussed. 4 of these are transverse and 1 longitudinal view to ensure that you're measuring the entire length of the abdominal aorta. And remember to measure outer wall to outer wall, and always include any thrombus within the measurements that you're taking. Finally, remember to document your findings and just keep the findings simple, showing that you've basically answered your binary question. So, thanks for watching. If you've got any comments, please let me know, and I'll try and make some more videos on other forms of PoCUS scans.